Before going on with the treatment options, let me talk a little bit about the anatomy. It's important to understand where the prostate's located, to understand what the potential side effects are and why they happen. The prostate gland is located between the bladder and the rectum. And because of that, it's in a space that can move around. And because the prostate sits directly against the bladder, when we radiate it, we can't avoid the entire bladder. It's almost like a fist against a balloon. And right there, and since we have to get the top of that fist to a good dose, that part of the bladder has to get a high dose as well.
Whether it be with external beam radiation or with protons or with seeds.
Again, the prostate also sits on top of the rectum, and that anterior rectal wall is right on the other side of the prostate. Therefore, that anterior rectal wall goes to full dose. Here's a little model of the prostate being here, and you can see it's directly underneath the bladder, so this wall is in direct contact with the prostate. And again, here's the prostate, and here's the rectum. This is how we do a digital rectal exam and feel the posterior portion of the prostate. It's important to realize that these structures are here because no matter how we radiate patients, there will be some spillover radiation to these structures.
The sole purpose of all of our improvements in the radiation technique, including the hardware, the software, and the imaging, is to more precisely target the prostate and therefore minimize the amount of normal tissues that are in the field.
The first option is external beam irradiation, and again, that's what we call intensity modulated radiation therapy. And that's the most advanced form of external beam radiation we have today. The first thing we do is a CT scan. It's a planning CAT scan in the treatment position with some contrast in the bladder and contrast in the rectum. That allows us to more clearly delineate those organs. It's important because we need to be able to draw those structures in so we know where we want to aim and what we want to avoid. We also draw in the prostate and the femoral heads. After the CT scan, we may send patients also for an MRI. The MRI gives better delineation of soft tissue in certain circumstances and can allow us to better plan where the radiation needs to go. We can take the information from the MRI and fuse it with the information for the CT scan, enabling us to more closely target and approximate the diseased areas within the prostate itself. With that information, that goes off to the dosimetrist. The dosimetrist does a plan. The plan encompasses those structures, what we want to treat, what we want to avoid, and looks at different ways to treat them and maximize coverage. After the dosimetrist does an initial plan, we review it together to look at this coverage. We can look at what areas are cold, what areas are warm, how we can best optimize the plan for each individual patient based on the patient's anatomy. Following completion of the plan and approval by myself, the plan is then reviewed by the physicist. The physicist checks it for accuracy and then runs the entire plan on a phantom. By running the entire dose around the phantom, we can measure and ensure that what the machine is delivering is exactly what the computer says it is.
Once this is complete, we'll bring in the patient for the first treatment. At the time of treatment and every day subsequently, we'll set the patient up to the tattoos. After that, the therapist will take pictures, one from the front, one from the side, and with those they will localize the coils that were placed in the prostate or the prostate bed for those patients who have had surgery. They'll run a three-dimensional software program and then the physicians review it. That will happen prior to beam on every day. The shifts are then made and the treatment is delivered. This allows us to approach the prostate with a sub-millimeter accuracy and to minimize the amount of normal tissue that is in the field and in the beam.
We treat you once a day, Monday through Friday, 5 days a week. Most patients are between 7 and 8 weeks, and it takes less than 10 minutes. Each week, I'll see you under treatment to see how things are going, see if there's anything I can do for you to give you assistance, and talk about potential side effects. And I'm going to get into those in just a little bit.